These are my disclosures. I won't go through the definitions that Hendrik has very nicely covered. NIH has made major calls to fund translational medicine. So I took this opportunity to have a think about how we're faring on what they would suggest we should work on translational medicine in relation to minimal hepatic encephalopathy. So how well are we doing with minimal hepatic encephalopathy in terms of collaborations between researchers and clinicians, leveraging new technology and data analysis tools, and increasing the speed at which a new drug reaches patients. And unfortunately, but I am sure it will be no surprise, it looks like we're not doing terribly well. We have a gene that has to do with predisposition to the development of hepatic encephalopathy. It got published a few years back, no less than on Annals of Internal Medicine. And every time I see Manuel, he says how disappointed he is that nobody is replicating, is trying, is playing with this. We have an app, although this is younger, so maybe we'll see people using it, trying it, seeing how it works. In my view, we have a disease that in many respects is so fancy that we can cause it. You know, it is extraordinary. There are not many places in neuroscience, neurology, psychiatry, where you can simulate or cause a very similar syndrome to the one you're studying with by feeding people protein. And I think very little use is being made of this possibility. We've had bedside tools for years, and we've spent years discussing whether they are appropriate or not. We have a blood test, which I think is tremendously useful. And we've spent a lot of time convincing everybody else in gastroenterology or in other fields that it is not useful. And there is virtually no relationship with absolute glucose levels and diabetic coma. But you will find no diabetologists going around telling people that they shouldn't measure glucose. And finally, you know, one of our big hits, which was a very important moment for our community, a trial on New England Journal of Medicine, very welcome, but it was on a drug which has been around and licensed in Italy for this application, out of all places in Italy, for maybe 35, 40 years, and we've been using it all the time. So why can't we do, or why do we have some problems in doing translational medicine applied to minimal hepatic encephalopathy? And I've tried thinking about this because I don't know normally, you know, this was an occasion to reflect on this. I've tried to identify some obstacles, if any, and I found 4. And I think the first major thing is confusion on the definition. I think this, again, the audience will agree on this one after this morning and after the last few days. Use of minimal hepatic encephalopathy as a standalone, regardless of encephalopathies of other sizes. What I like to call the statistical approach to minimal hepatic encephalopathy, and I'll try to make myself clearer as I go along with the talk. And finally, very limited work on the difference between a patient with minimal hepatic encephalopathy and an unimpaired patient. We've discussed about covert, overt a lot. So the right-hand side border, what's the difference between a minimal and overt? But we have discussed and worked much less on what is the difference between a minimal and an unimpaired. And it is my impression that this should be done and may be relevant. So I'll start off with the confusion. We've written on this. Many people have talked about this over the last few days. We've allowed ourselves and colleagues to call minimal hepatic encephalopathy any sort of disease. Cerebrovascular disease, hypothyroidism, malnutrition, electrolyte imbalance, sepsis, pH disturbance. You only have to open the literature and, you know, it will all be there for you to pick. Even the side effects of drugs such as opioids and benzodiazepines. And it is difficult enough I don't have much experience in the field, but for those of you who have tried, it's difficult enough to do clinical trials and drug trials when the population is reasonably homogeneous. If the population is like this, I think there is virtually no hope to see or understand how things work. So second point, we've worked on minimal hepatic encephalopathy as a standalone. And I took this example of a piece of work that I did with Marcia when I worked at the Royal Free. This is an EEG index, but I could have taken anybody's piece of work in the field. And when I worked at the Royal Free, Marcia would always say, I'd come up with something, show her some results, and she would say, where are the overts? In other words, we were working on a simple, but on an important check, that whatever we used in these patients and seemed to be useful to diagnose minimal hepatic encephalopathy, the overts had to do worse with. In other words, the minimals, in our view of the disease, how it was, had to stay in the middle. And there are caveats to this. We know that some tests the overts can't do, so they can't be shown to do worse. But as a general frame, as a check of what we're actually doing, I think it is important. And you know, again with Marcia, we did eye movements, and again the minimals were, you know, this is how an eye follows a track, and this is a healthy volunteer doing very well, an unimpaired doing very well, and you see a minimal, they make a lot of mistakes, saccades in truth, and the overts does much work. So again, the minimal in the middle. Because if you don't do the minimal in the middle, you come to what I like to call, and maybe the native English speakers will tell me a better way to qualify this, the statistical approach to minimal hepatic encephalopathy. This is a very nice old editorial by Van der Rijt and Schalm, who used to work in Rotterdam on the electrophysiology of hepatic encephalopathy. And this shows the prevalence of different electrophysiological abnormalities with big confidence intervals in patients with cirrhosis with no overt abnormalities, so who were either unimpaired or minimal. And the comment in the editorial is, as far as we know, no study reported the correct sensitivity of the test defined as the number of patients with abnormal test results in a group of patients with what used to be called latent encephalopathy, already diagnosed by a method considered the golden standard, for instance, psychometry. And the only studies available in '92, but the situation hasn't changed enormously, report percentage cases with test results above the upper limit of normal in group of patients without clinical signs. So how are we working? We take a test that has some neurological or psychiatric relevance. We do it in a group of healthy volunteers. Then we do it in a group of cirrhotics without overt hepatic encephalopathy. And we find that this test is more often abnormal in patients. I mean, can we be sure? Can we call this minimal hepatic encephalopathy? Or should we make some cross-checks? Should we check that it relates to the degree of liver failure? In the end, we have a disease that is due to liver failure. Should we check that it relates to other recognized relevant measures of encephalopathy? Should we test, again, MHE in the middle, that is more often abnormal in overts? Should we check that it predicts overt? I think Manuela and Oliviero Riggio in Rome have made a big point of this. You know, is it important that whatever we use to diagnose minimal has some relevance to the likelihood of our patient developing overt? And in our view, the answer to all these questions is yes. Yes, we should check. And my final point, MHE versus unimpaired. So again, if we take the slide of in the middle, this is a reference population, and these are all our patients with cirrhosis. These are the overts, these are the minimals, and for a moment I would like us to concentrate on what we call the unimpaired. So in this specific study, these were individuals who had no FES and no EEG abnormalities. And you can see that they are in the middle too. And they are in the middle between unimpaired and minimal. And this is often the case. If you open the literature and you find clinical studies on HE, you, not always, but you often find yourself in this situation that the average well cirrhotic still does worse than the healthy volunteer of the same age and educational attainment, or whichever attainment is relevant to your test. So we often ask ourselves, you know, what is this? Is this previous alcohol misuse if the population has many alcoholics? Is this HCV? Is this malnutrition? Is this overweight or diabetes if the population is full of individuals with NASH and fatty liver and what have you? Is it bad sleep? You know, if you sleep badly in the long run, you won't perform. Is it the drugs they're taking? This has been touched upon. Is it cirrhosis itself? Or is it the extra minimal HE, a form of encephalopathy that is just the same in the spectrum but doesn't meet the criteria, but it's the same thing? And I think this is these are very potentially very important questions to answer, because they may have consequences on several concepts that people are working upon. For example, an important one, in my view, is how this is relevant to what we see after transplantation. So is this the irreversibility that has been talked so much upon? And I think data are starting to emerge to suggest that this is the case. This is data from Padova. Francesca worked on this. And you see, they studied a very large group of patients before and after transplantation very extensively. And these are the results of the EEG in patients split as having or not having overt HE prior to transplant. And you see, they all normalize. No EEG abnormalities after transplant. And this is the same for psychometry. You see that they improve enormously, but they don't match the people who never had hepatic encephalopathy before. So is this difference here made up of a bit of hepatic encephalopathy and maybe a bit of this pink that is pink here as well that made them do worse before? And I don't know the answer to this, but again, I think it's relevant. So if this is the case, so if in some ways our situation before we even get minimal hepatic encephalopathy affects predisposition and affects reversibility, then we have to look at the stories and the models we've been looking at in the last few days in a slightly different way. So if you're a relatively healthy young person with hobbies and a good level of education, you have a beautifully colorful and wired up brain to begin with. Then, for some various reasons, you get cirrhosis, and your brain, it fades a bit, but not much, and you may get a bit of minimal or, just very, very minor abnormalities. You're lucky, you get a transplantation, and you go back to a beautifully wired up, colorful brain. But if you didn't start off with a colorful brain, because you had drunk on it, because you were overweight and diabetic, because you had thiamine deficiency, because of any godforsaken reason, some of which we know and some of which we don't, then you get cirrhosis, and then it gets serious because you had a frail brain to begin with, and then maybe you get overt and you suffer much more from the same ammonia load. And if you get a transplant, you go back to your gray brain. You don't get a colorful, flashy one. And we all know this is the way Piero likes to put it in our lab. We all know that if you are limping to begin with and somebody puts an obstacle in front of you, you will be more likely to fall than people who were fit to begin with. And possibly more importantly, you will still be limping after the obstacle, or possibly limping even more. So I think this is why we've been looking a lot these ways, but we should maybe start to be looking this way. This is an area that has been receiving much attention, not in our field, but in parallel fields. This is a beautiful review on The Lancet about the likelihood of old people being hospitalized, getting an episode of delirium or mental confusion. And you see that if you have low vulnerability, you need a big insult to get the syndrome. But if you have high vulnerability, you only need a little push to become confused and to have an episode of delirium. And again, this year, just to give you a feel for how relevant this is felt to be with, another review on the same topic, but about delirium in intensive care, with all the possible reasons, comorbidities, risk factors that could explain why some people who get into intensive care, regardless of the severity of the disease that took them into intensive care, develop delirium and others don't. And you see there's pretty much everything we've been talking about these last few days. There's comorbidity, there's the severity of the illness, there's age, there's substance misuse, there's noise, there's sleep deprivation. And I really do think that it is the way to look at every single factor patiently and slowly and tease out the role it could have to our field. And some of it has been done. Manuel and now Hendrik and other people are working on diabetes. Jazz works on predisposition and the microbiome. Rajiv and several other groups have worked for years on inflammation and infections. We've done sleep in England, in Italy, and I do think this is the way, teasing out things one at a time. This is an era, it is our impression, for a pathophysiological approach. It is no more era for a syndromic approach, and it is not me saying that. It is the director of NIH Mental who observed, and it came out on Financial Times, that symptoms alone rarely indicate the best choice of treatment, and we need diagnostic systems that are more directly reflecting modern brain science. Thank you.